And it's at this time we are here for Genetics 101 with Dr. Tyler Reimschisel. He received his bachelor's degree in history, philosophy, and social studies of science and medicine at the University of Chicago and his MD at Rush Medical College, after which he completed residencies in pediatrics, child neurology, and medical genetics at Johns Hopkins Hospital. He is currently assistant professor of pediatrics and neurology and director of the Division of Developmental Medicine and the Center for Child Development at Vanderbilt University School of Medicine, where he is also the associate director of the pediatric residency program, director of the leadership education in neurodevelopmental disabilities training program, and vice chair for education in the Department of Pediatrics. Dr. Reimschisel's clinical interests include evaluation and management of children with inborn metabolic diseases and other genetic conditions that cause neurodevelopmental disabilities, such as global developmental delay, intellectual disability, epilepsy, cerebral palsy, and autism spectrum disorders. Thank you.
Okay, good afternoon. I'm going to try to untangle this cord so I can walk around. How many of you were here yesterday morning for this session that I gave? Okay, this is similar, but what's going to be different are the questions that you're going to ask. So we have, I think, the next hour or so to discuss some basics about genetics and how it relates to mitochondrial disease. And so please ask questions so that you understand what we're saying. And we should also have time to get to some of the clinical manifestations of mitochondrial disease, but you certainly know those well, so if we don't get to that portion, that's fine. Yesterday we really focused mostly on the genetics of mitochondrial disease, and that's what we're going to do today. And I appreciate the kind introduction. And for those of you who are not from Nashville, how many of you are not from Nashville? Yeah, that's what I thought. Welcome. I've now been here for 10 years, so it's now home. And this is a cool summer day in Nashville. So let's see if this is going to work. It is not working. I should do it this way. And that's not working either. Okay, well, we may just have one slide for the whole show. Yeah, none of them is working actually.
Oh, cute. Escape.
There we go. If I just do,
Do you want me to
we'll
do
see
that?
if that works. No, that's okay. I got it. Thank you. No, it's working. Okay, so what I'd like for you to learn by the end of the hour is how to distinguish mitochondrial disease from mitochondrial inheritance. And that's inheritance in the mitochondrial DNA. And then we're going to talk about specific and unique aspects about diseases of the mitochondrial DNA. And so you're going to learn some terms or be reviewing terms called polyplasmy, heteroplasmy, and threshold effect. And then if we have time, we'll get to the clinical features and the laboratory features of mitochondrial disease. So it's really a very basic overview. But I think that in my experience, if you know this, you know more than most healthcare professionals about mitochondrial disease. So, it is scary. Whoever said that, it is very scary. Yeah, so that's why we have to do more of these sessions, I think. Okay, so I'm going to start with a case of a patient who I still follow. At the time that I met her, she was a 17-year-old girl who presented to our emergency room with new onset seizures. So she had never had a seizure before. She presented to the emergency room. And because it was a generalized seizure, she was sleeping in the emergency room, and they couldn't really get much history from her. And so they did some laboratory work. They found that her glucose was fine, so she didn't have any trouble with a low glucose, which would certainly cause a seizure. They had done a white blood cell count, which was normal to rule out infection, but they noticed that she had severe acidosis in her blood, so there's too much acid in her blood, and they're going to try to figure out what is that acid, with some follow-up testing. So they were waiting for the labs to come back, and her maternal aunt arrived with her hearing aid. So the patient had a history of hearing impairment, and the aunt said that the patient's mother had died after having several strokes, and the patient's maternal grandmother had also passed away after having several strokes. And there were several living family members who also had hearing impairment. So they were trying to figure out what was causing the acidosis, so the easiest test to get is to get a lactate level, and when they did that in hers, it was 9.7. The normal range is 0.5 to 2.2, so clearly 9.7 is very high relative to what it should be. They repeated it just to make sure it was accurate, and many times we do that because lactic acid levels can be falsely elevated if they're not processed correctly, if it sits in the lab. And so they did it again, and it was still very high. And now they want to see if there's any evidence of an impact of having a mitochondrial disease in different organs. So that's what they're looking for now. So the first thing they do is they look at the liver enzymes. So these are enzymes that are working in your liver, and if the liver is damaged, the cells spill or open up, and those enzymes get into the blood, and then when we take a blood test, we see these elevations. So it's an indication there's been some damage to the liver. In her case, they were normal. So the AST and the ALT, which are the names of those enzymes, were completely fine. Then they also wanted to look at the CK. The CK is an enzyme that comes from your heart or your skeletal muscle, meaning the muscles that move your arms and legs. And those were also normal in her. But in a person who had significant mitochondrial disease of the heart or the muscle, those could actually be elevated. And so it's an indication that at least in her at this time, it doesn't appear that those organs are that severely impacted. They looked at the plasma amino acids. The amino acids are our building blocks to protein. And one of the building blocks of protein is alanine. And I'll show you in a diagram in a few slides that alanine is frequently elevated when lactate is elevated for a prolonged period of time. So this alanine being elevated was indicative of the fact that her lactic acid had been high for a very long time. And then they did a urine test where they also found elevated lactate and pyruvate. Similar to alanine, pyruvate elevation and lactate elevation frequently go together. And I'll show you in a diagram in a moment. But these are all sort of hanging together that we now know what's causing the lactic acidosis. She has elevated lactate, and it's likely that she has some impairment in her mitochondrial function. And so I'll show you again in a slide how that works. Now what happened was the resident who was on call in the emergency room called me. I was on call for neurology, and he said, he placed the call around 2:30 or 3 in the morning, and he said, I have a patient that you're going to be really interested in. Okay, at 2:30 or 3 in the morning, that's not usually what you're thinking, but when he gave me this family history and these labs, I was like, yes, it turns out I am quite interested in this patient. And so this was concerning for mitochondrial disease, and so not in the emergency room, but later on, we did sequencing of her mitochondrial DNA, and it showed a common mutation that's seen in MELAS. And so she and her family were diagnosed with MELAS, basically. So the next part of the story is that she has continued, I can just show you this slide, but she has continued to have strokes, and because of the accumulation of the injury that the strokes caused, she developed epilepsy, and now has stiffness, has a movement disorder. So I still follow her. She's, I think, now about 22 or 23, so I followed her for about 5 or 6 years. So she has acquired some disability related to this. She hasn't had as many strokes recently, interestingly enough. I don't know why it's changed, but so anyway, she was diagnosed with MELAS. So this is a really classic case of a mitochondrial disease due to mutations in mitochondrial DNA, but not all mitochondrial disease is due to abnormalities of the mitochondrial DNA. A lot of it is due to abnormalities in the nuclear DNA, and that's what we're going to unpack over the next few slides. So the first thing is that you may hear this term mitochondrial cytopathy. Raise your hand if you've ever heard anybody say mitochondrial cytopathy. Okay. So really what that means is you have a defect of the part of your cell in the mitochondria that makes energy. And the energy it makes is called ATP. So if you have trouble making ATP, and that pathway that does it is called oxidative phosphorylation. If you have a defect of oxidative phosphorylation, or the pathways that feed into that, you have a mitochondrial cytopathy. There are other things that happen in the mitochondria. It's where we break down fat. It's where we metabolize some of our protein. But those conditions are not referred to as mitochondrial cytopathy. So really, mitochondrial cytopathies are what we focus in on UMDF and those kinds of conditions. The other thing that this slide reminds me to talk about is secondary dysfunction. So again, we are focused on primary dysfunction of the respiratory chain, oxidative phosphorylation. It's the same thing. It's what's making ATP. But we know that common conditions can also have secondary problems in the mitochondria where that process doesn't work. So for example, Parkinson's disease, Alzheimer's, Huntington disease, those conditions are not primary mitochondrial diseases. The defect is not focused initially in the respiratory chain or making energy. But those individuals who have those conditions have secondary dysfunction of the mitochondria. And we think that that secondary dysfunction of the mitochondria makes the primary disease, whether it's Parkinson or diabetes, worse or better, right? And so we're actually interested in studying some of those other diseases, like what is the mitochondrial disease, what is the mitochondrial contribution to Parkinson's disease? It's not the primary, what is the mitochondrial contribution to aging, right? We know that as we get older, the mitochondria are not as healthy, right? But we wouldn't say aging is a mitochondrial disease. It's more that there's a secondary influence from the mitochondria getting sick on aging. And so the UMDF and other organizations like the NIH, which you've heard about this week, are funding that kind of research too, because we think that what we learn in those diseases can help us understand primary mitochondrial diseases like MELAS and MRF and the other conditions that you've heard about this week and you yourselves are experiencing or your families have. So that's just a little bit of an explanation about some of the different terms that we use. Okay, so let's start with what everyone knows, the cell. So you've probably seen this. My kids, make the cell in some of their elementary classes, right? And so here in the middle of the cell is the nucleus. What is in the nucleus? DNA. Yeah, that's right. And it's in our chromosomes, right? Okay, here is a single mitochondria. Now this is a simplified cell because it only has one mitochondria. This would be a cell without a whole lot of energy if it only had one of those little things. So it actually usually has tens, hundreds, or thousands of them, but for the sake of illustration, there's just one, right? And so there is a little mitochondrion. In the mitochondrion, there are these pathways like the oxidative phosphorylation that's making energy, but there's something else in that mitochondrion. DNA. That's right. That's pretty cool. Okay, right away you know more than 98% of the population in the planet right there, because everyone thinks that all of the mitochondria, all the DNA is in our nucleus. A large percentage of it is in the nucleus, but not all of it. Okay, so here's what we're going to do. I'm going to do similar to what I did yesterday because I think this helps a lot. When we're talking about the DNA that's in the nucleus, that's going to be over here. So over here is this big nucleus. We're just at the edge of it. So pretend you're inside a cell, right? And over here is the nucleus, and there's the DNA. So anytime I talk about the nuclear DNA, which is the vast majority of DNA, I'm going to point over here. Over here on this side of the room is the mitochondrion, right? And there's a little bit of DNA over there. And that DNA that's abnormal has unique genetics compared to the DNA that's over there in the nucleus. So we're going to explain that a little bit more. Now, if you could just pretend that this was on your smartphone, and you went like this on your smartphone to make that mitochondria get bigger, okay? What you're going to notice is there's a ribbon inside there. There's like one membrane and a second membrane. When you go to make it bigger, it looks like that. Look at that. Is that cool? We just made it bigger. And so now we focused in on the mitochondria. And instead of being green, it's gray. But there's two membranes, one here and another one there. The outer mitochondrial membrane is called the outer mitochondrial membrane. And the inner one is called the inner mitochondrial membrane. Very creative we are in medicine. This is really important. Those two membranes, if they're not intact, they're not healthy, you can get mitochondrial disease. So one of the diseases we know of that affects individuals if they have dysfunction of the intermitochondrial disease is Barth syndrome. Actually, some of you have heard of that, but it's a condition that affects primarily boys. And it's due to the fact that there's a protein in the intermitochondrial membrane that's not healthy. So those two membranes are really important. Now, we're going to start up here. You'll see alanine, lactate, and pyruvate. And remember I said those were in equilibrium with each other. So when pyruvate builds up, alanine builds up, lactate builds up. So in this individual, she had a high pyruvate, lactate, and alanine. That's pretty common for people with mitochondrial disease. It is not necessarily the case, though, that every person with mitochondrial disease has an elevated lactate or pyruvate or alanine. And most of the patients I have with mitochondrial disease do not have elevations of those. Right? Which gets to the main point that, as you know, there is no gold standard, so there's not one single test that we can order that in every individual with mitochondrial disease is abnormal. Right? Okay, so way up another part of the cell off the slide would be glucose. And glucose goes through a bunch of different steps. And the end product of breaking down glucose, when you're breaking down sugar that you eat, like you just had lunch, is pyruvate. So those steps are not on this slide, because they don't happen in the mitochondria, it turns out. They happen outside the mitochondria. But once we get to mitochondria, pyruvate is there, and then it goes through this cycle called the Krebs cycle, and then it goes through these complexes to make, right there is ATP. You can see that? But ATP is the energy that the cell uses to function, and so it has to metabolize pyruvate through this cycle, and then through these 5 complexes to make ATP. There are 5 complexes, again, creatively called complex 1, 2, 3, 4, and 5. And so this diagram shows them as circles or ovals in just one of them for each of the complexes. And that is absolutely incorrect. So now I'm going to get into a little bit more detail. And I did this by just making a table instead of a picture. So now what I've done is each of these columns is representing one of the complexes on this previous slide. Here's complex 1, 2, 3, 4, and 5. And so each of these columns is one of those complexes. The second row is the scientific name for those complexes. So when you have a name, NADH dehydrogenase ubiquinone oxidoreductase, you now know why we call it complex 1. So complex 1, it turns out, is made up of many, many, many subunits. 45 of them or 47 of them, we're not exactly sure how many subunits are, but there's at least 45. So the purpose of illustration, let's go with 45 subunits. Each subunit is a protein, and it has to be encoded by DNA. Now we're back to DNA, right? You don't just get that protein. You have to make each of those subunits. So of the 45 subunits, 7 are made from the mitochondrial DNA, which is over here. Right? And it stays in the mitochondria. So there's DNA there. It makes that protein one of the subunits of complex 1, and it stays in the mitochondria. But the other 38, did I get that right? 38 of those subunits are encoded by DNA or genes over in the nucleus. So that DNA makes those subunits, and those subunits have to be transported over into the mitochondria, put into the mitochondria. And those transporters also take proteins that are encoded by the nucleus. Right, so that's a lot of genes just for complex 1. Complex 2 has 4 subunits. None of them are encoded by mitochondrial DNA. All of them, there are 4 genes over in the nucleus. They make those subunits and they have to be transported over to the mitochondrium. And we won't go through each one. You get the idea, right? But you can see that if you were to add up all the subunits and then look at how many of them are encoded by genes over in the mitochondria, the vast majority of the genes are encoded over here in the nucleus. They're not encoded by genes in the mitochondria, right? And then you have to have all those proteins that transport it into the mitochondria. You actually have to have proteins that bring in the building blocks of DNA. So just like I said, amino acids are the building blocks of protein. There are building blocks for DNA, and those building blocks have to be put in the cell too to make the mitochondrial DNA. And that requires genes over the nucleus. So altogether, there are about 1,000 different genes that are important for the mitochondria to work well. And the vast majority of them are encoded by the nucleus, from genes in the nucleus. Okay, so Let me just talk a little bit about the genetics of mitochondrial disease due to nuclear gene abnormalities. Most of those conditions are autosomal recessive, which is the medical term for when the parents are each carriers, but they themselves are healthy. So we have 23 pairs of chromosomes. I'll show you this in another slide. One of those chromosome pairs comes from mom, and the other chromosome pair comes from dad. And for those mitochondrial diseases that are due to mutations in the genes over here, in the parents, only one of the copies that they themselves have is abnormal. But in the child, both copies, the one from the dad and the one from the mom, are abnormal. And that's why they develop the disease. That's called autosomal recessive. So the parents are healthy, but the offspring who are affected have two abnormal genes, one for mom, one for dad. Okay? And that's the inheritance pattern for most mitochondrial diseases, is autosomal recessive. There's a recurrence risk in the same couple of 25%. Most people think that mitochondrial disease is always due to mutations over there, and the inheritance is maternal, which we'll get back to. And that is true for MELAS, which was what the girl in the case had. It's true for many conditions, but it's not true for the most mitochondrial diseases. Okay? So let me show this one slide, and then I'll pause and let you ask me questions. If you could just memorize this slide in the next hour. That's good. You all knew that was a joke. When I do this to medical students, they all start writing frantically. Okay, so what this is products of genes or proteins that are known to be mutated in respiratory chain disorders grouped by pathway. So now this is a table that's representing everything I said. Right? So you need genes for all of this to happen. So the first group of genes you need are the genes that are actually going to make subunits for those complexes. Right? And so that's what's shown in the first table. So of the nuclear encoded genes, the genes that are over here, there are genes that encode subunits for complex 1, 2, 3, 4, and 5. But here, for the mitochondrial DNA encoded, so that's the DNA that's over in the mitochondrion on that side of the room, there's genes for complex 1, 3, 4, and 5, but not for 2, right? Because remember, complex 2 only has nuclear encoded genes. And this doesn't list all of the genes, it's just a representation. Because we know complex 5 requires a whole lot more than one gene. There are several subunits there. Then you have to have products or proteins that maintain the mitochondrial DNA. So there's mitochondrial DNA over here, and it needs to be kept intact, kept healthy, right? And that requires proteins. And those proteins that do that are encoded by the nuclear gene over here. Nuclear genes. Then it says oxidative phosphorylation, biogenesis, and regulation. That's actually, we got all these subunits, like 47, 45 subunits, and we got to put them together, right? We got to build it. So you made one subunit and another one. Now we need to put them all together in the right format. It's like building a house out of Legos. There's got to be some proteins that put the Lego pieces together, not just make the Legos. And all of those building material, all the builders, let's say, for the subunits and the complexes are encoded by nuclear genes. And then the last two are getting the pieces of the mitochondrial DNA into the mitochondrion and maintaining the membrane. Remember I said those two membranes are really important? Got to be healthy membranes, keep them intact, repair them if there's any problems. There's proteins that do that. So it's really complicated. The only genes that are over in the mitochondria are these down here. All of the other ones are in the nucleus. Okay, I'm going to pause there before I go on, because the next thing we're going to do is talk specifically about the mitochondrial DNA. Before they do that, tell me what I've said that's unclear or you want me to restate in English. Yes?
Are you going to talk about autosomal dominant?
I can. Sure. So autosomal dominant means that only one of the two genes that we have has a mutation in it, and that's enough to get sick, basically. That's enough to cause a clinical problem. The vast majority of mitochondrial diseases are autosomal recessive. Only a few are autosomal dominant. And so It is true there are some autosomal dominant diseases that individuals have that can cause mitochondrial disease, but they're pretty rare. The most common is autosomal recessive, which is why I focused on that. There's also another form called X-linked, which is on the X chromosome, which is unique because men and boys only have one X and girls have two. And there are some genes on the X chromosome that cause mitochondrial disease, which means those diseases would be more severe, generally speaking, in boys than in girls, but those are really rare too. So, I have an example on a subsequent slide where there is one clinical presentation and it can be mitochondrial, dominant, recessive, or X-linked, actually. But that's, yes?
Are there ever multiple genes in the sense that, like, there can be an mtDNA inheritance that maybe has a mild effect, but then there can be autosomal recessive ones, and then it all comes together in one kid?
You're right.
Is that
Probably so, because we think that's true for all genetic diseases. Even, we have this very simplistic view that genetic diseases is one gene, but it's really not. Because if you take any genetic condition, separate from anything related to mitochondria, you think of any genetic condition, so cystic fibrosis, sickle cell disease, achondroplasia, risk for breast and ovarian cancer, there's a lot of variation even within that one disease, and we think that part of the reason for that variation is all the other genes that are contributing to that. And so, yes, there is definitely going to be, if you have an abnormality in the mitochondrial DNA, we believe that changes in your DNA over here can either make that disease less severe or more severe, but I don't have any specific examples of that. But theoretically, we're pretty sure that happens. Yeah. It's a very good question. I just can't give you a specific example. Yeah. Yes?
Isn't that an amino acid disorder where you can't break down proteins correctly?
Yes.
Is that mugged up any of this? Is protein itself?
No, because where we break down proteins is in a different part of the cell. It's not in the mitochondria, it's in the cytoplasm, most of it, and so it doesn't have a direct impact on this typically.
Because the amino acid disorders, could they cause secondary mitochondrial disease in your experience?
I guess they could. I've not seen that. I take care of kids with all kinds of disorders of their biochemistry, and it's not something that's real prominent, I would say. We have enough on our hands just to address the primary defect in breaking down those amino acids that we probably really haven't looked carefully at the mitochondrial contribution to that, but it's probably similar to other conditions I was mentioning earlier, like Parkinson's disease or diabetes or aging, where we know that there's some contribution, but it's not something that clinically we really focus in on a lot. Yeah. Yes?
Our daughter is diagnosed with pyruvate dehydrogenase disorder.
Yeah.
A random mutation, or as the genetic report says, variant of uncertain significance. Is that rare, or is that
Yes.
fairly common?
No, it's rare. But everyone in this room we all, and what I see in clinic, are rare conditions if you think about from a population. So what that is saying is that here's pyruvate dehydrogenase complex that converts pyruvate to acetyl-CoA, and this oval is really 4 subunits. 3 are, they're all in the nucleus, let's say. The most common is the one that's on the X chromosome, and so that may be the one that she has, yeah. Now, when you say variant of unknown significance, that means that they're not entirely sure it's absolutely a pathologic mutation. It's something that's unusual. It could be a pathologic, meaning it could cause disease, but they're not sure about it, just based on what you read. And then there's other things you can do to clarify that, but
Okay.
yeah.
Thanks.
Yeah, but it is unusual, and that is definitely, so let me just say, the reason I put this slide here, that would be considered a mitochondrial cytopathy. It is a mitochondrial disease because it's all related to this whole pathway. Yeah. Other questions or comments? Yes?
First off, I'd like to thank you for having personality. It's nice to have it.
Well, thank you. That's very kind of you. I have a bow tie on sometimes, so that really, he doesn't have a bow tie on today.
That would throw us off.
It
That's
does.
casual Saturday.
You're right.
We have 5 kids that are affected. My wife is affected. But they all show, one was diagnosed down at Johns Hopkins, and they gave us some numbers back in like 94, I think. And they show different symptoms. Now, there's some of them, they've gotten a lot better. 2 of them used to power a wheelchair through school. One has 4 kids, and
Great.
he's doing pretty good. And the other one is just starting to have more vision problems. He's 31. But Is that normal that you're not, even though they told us that everybody basically has the same number. Her mother had problems, her grandmother, her great aunts. So you can see it come down through the family.
Yes.
And, but the fact that they're all, none of the symptoms seem to be the same.
Right.
When they were younger, they had a lot of bradycardia. They were
Yes.
three of them on monitors. But do you see that often?
Yes. And your question to fully
I was going to say, if you don't mind repeating.
repeat it, yeah. So the question was, in a family where a mother's affected and there are 5 children, all of whom were affected, but the 5 children have different clinical manifestations, different clinical problems, and the severity is different and it's changed over time. So the question is that common? And the answer is yes. And for me to explain that, I'm going to talk about mitochondrial DNA. So your question is perfectly placed. So I'm going to go through this in a few slides and I'll come back and explain why there's all that variation.
I asked you where you told me to ask it.
Yeah, it was great. Yeah, and I'll pay you later. I hope I have some. Actually, I can't pay you later. I work at Vanderbilt, so I can't afford that. Just kidding. Sort of. Okay, so let's do a little quiz here. So I said the nucleus over here has most of our DNA, and the DNA is in letters, A, C, T, and G's. Lots and lots and lots of letters. How many letters over here in the DNA in the nucleus? One nucleus. 200,000. Anyone else want to say another number? Yes.
If I remember right.
Yes?
6 billion?
3.
3.
Good job.
Almost 3 or 6. I couldn't remember exactly.
3 billion. How many? So this is better because yesterday I said how many and somebody said a lot. I'm like, okay, that's true. I mean, I can't say you're wrong, but so 3 billion. How many letters is that? How can you visualize 3 billion? Well, if you were to put those letters in Encyclopedia Britannicus, so how many remember the Encyclopedia, the sets, right? So sets in Encyclopedia Britannicus, it had the letters and then it had like topical books, right? So it wasn't just A, B, C, D, it had a lot of books, right? So 3 billion letters would fill 13 sets of Encyclopedia Britannicus. Sets, not just single books. For those of you who are younger, a book is a thing, it's a physical structure. It doesn't scroll, if I say, well, yeah. So that's a lot of letters, right? 3 billion. And that's in every single nucleus in every cell, right? So it's a lot of information. Over here, there's only 16,569 letters. Much, much, much smaller. Right? So that's why I've been emphasizing the importance of the nucleus and the DNA in the nucleus. And so, how many genes do we have over here? So 3 billion base pairs. How many genes are there? 20. Who said that? 22. You guys are right on. 20 to 22,000. But the reality is, you'll be like, okay, he just said 20 to 22,000. That doesn't really sound like a specific number. Like, I guess we got in the ballpark there, but yeah. So we don't know how many genes there are. So I explain this to the patients that come to see me. We don't know how many genes we have. So if we can't give you a number, then we certainly can't answer these great questions you're having, like, can genes work together to contribute to disease, or even take one gene? What are all of the different clinical problems one gene can cause? Well, we don't know how many genes there are. We don't have the answer. So we're pretty dumb, right? So what I said yesterday, when you go see your geneticist, just keep reminding yourself how dumb that person is, right? I mean, there's so much we don't know. And what that means, practically speaking, is that you can do testing for people who have mitochondrial disease clinical presentations and get normal genetics, and it doesn't mean they don't have a genetic condition. It just means we aren't smart enough to figure it out yet. And I know that can be very frustrating for you and very just frustrating and disillusioned, and you get, right? But it's helpful for you to have realistic expectations about what we can do from a genetic standpoint, because there's so much we don't know.
I hate to interrupt, except to say,
It's okay.
I'm not so frustrated as I'm frustrated with the doctors who think that, sorry.
Who don't know, yeah.
Well, and some of them are here and considered very high in the miter world.
Right.
And still want to say, well, you don't have a genetic diagnosis, you only have a fresh muscle biopsy. We won't treat your child.
Yeah, yeah. Well,
And we
so what I will
I'm trying to
say,
educate some of them
yeah,
too.
what I'll say diplomatically is, to try to respond to that is, I do, and this actually sometimes makes my patients frustrated, because I really want a genetic diagnosis to be certain the person has mitochondrial disease, but if the testing has been negative, but they have features consistent with it, what I'll do is say, well, that's the best diagnosis we have at this point. Sort of say it's, what I put in my note is probable or possible, and then we do the treatment as if they, take the appropriate precautions. But what I don't want to do is have people stop thinking. So I have had patients sometimes even get frustrated with me. It's like, well, go to see another doctor, and they said I have mitochondrial disease, and now I come to you, and you say you may. And I said, well, I'm still going to treat you as if you have it, but I don't want to stop thinking, because it may be we learn something new. And so I'm sort of hedging my bets there a little bit. But we certainly don't want to withhold, like let's say we know that certain kinds of anesthesia can be risky in people with mitochondrial disease. Well, if you think you may have a mitochondrial disease, you should probably avoid that anesthesia if you can, and not wait for the genetic test. So then you take these precautions, right? So it really requires a conversation and saying, this is what we're going to do. I'm going to treat you with that. We can try some medications and things, but let's just keep thinking. It's sort of not harming the patient, but also let's not stop thinking about other things outside of it.
I like that much better.
Okay, so over here we said there's somewhere about 20 to 22,000 genes. Over there's 37, and only 13 of them encode subunits of the respiratory chain, and that's really all that it does, right? So it's much smaller. And so this is what it looks like, as opposed to it being on chromosomes. There, a single mitochondrial DNA is a circular structure that has all these 16,000 letters in it. You can't see the letters, it's just a circle here. And then what it shows is, you may not be able to see it from the back, but maybe you can see in your handout, is the names of the different conditions that are associated with pathologic mutations at that point in this circular genome, the mitochondrial DNA. So I'm going to talk a little bit more about now what is unique. So we're not going to talk anything more about the nuclear DNA for the next few slides. We're going to focus on the mitochondrial DNA, because this is going to be important for answering your question about this variation. So the mitochondrial DNA only comes from the mother. So as opposed to the chromosomes and the DNA over here, where you get one for mom, one for dad, over here it only comes from the mother, because in an egg that is fertilized, that's the mitochondria that goes to make the offspring, right? There is there is mitochondria in the sperm, but that mitochondria doesn't get into the egg and doesn't go to contribute to the offspring. So the mitochondrial DNA only comes from the mother, because that's where all the mitochondria comes from. Now once that happens, the sperm fertilizes the egg. It's a little bit of birds and the bees right now, but that's okay. So you form the zygote, it's called, the future offspring, and then that's one cell, and it divides and becomes 2 become 4, 4 become 8, right? And so as that process is going on, you're replicating the mitochondria, and you're just randomly separating the mitochondria. So if we're in a cell that's just been fertilized, and all the mitochondria over here will go to make the second cell when the cell splits, and the mitochondria over here will split, right? And it's purely random. So sometimes what happens is that just by chance, the mitochondria that are physically on one part of the cell have more mutations in it. And if they split off, those organs that are made from those cells will be sicker than the organs made from this cell over here. So that's one of the reasons why in the same family, the heart can be affected in one person and not in another. Or one person can have hearing problems and another person not have hearing problems. It simply is a randomization of which mitochondria go to form which organs once that zygote or the offspring is formed. And I'll show you what this looks like in a picture momentarily. If the mother carries the mutation in her germline, in the egg, right, then all of her children are at risk for having that mitochondrial disease. So 100%. But the severity is going to depend on the percentage of the mitochondria with the abnormal mutation. So if every child is at risk, but it doesn't mean that they're all going to have the same severity, because one egg may only have 2% of the mitochondria with the mutation, and another egg may have 90%. And so that offspring from that egg is going to be much more likely to be sicker than the egg with only 2%, right? So let me do a compare and contrast now to sort this out. So we're back to the cell. And what I want to say, here's the nucleus. Here's the chromosomes that you're probably familiar with, right? The chromosomes are numbered 1 through 22, and then we have an X chromosome and a Y chromosome. And there's 23 pairs. So chromosome 1 of these comes from mom, 1 comes from dad, right? And those chromosomes are what hold our 20 to 22,000 genes. But over here, it's very different. So in a single mitochondrion, one mitochondrion, there are many, many, many copies of the mitochondrial DNA. Many of those circles are donuts, right? Looks kind of like a donut. So whereas here, there's 2 copies of every gene, here there could be hundreds or thousands of copies of DNA. And that's called polyplasmy. So this is really important. We're comparing 2 copies to hundreds or thousands. And the reason that's important is that if you have, let's say, 100, just for simplicity, let's say we have 100 of those donuts or those circular mitochondrial DNA, right? What I've done now is I've colored them in that some of them are red or have a pathologic mutation, and some of them aren't, right? So this, if we go back to the case, would be like Milas, that we found that mutation in our patient. And so not every single circular DNA in her mitochondria has that mutation. Some do and some don't. So some are red, and they have mutation, and some aren't. And so what that means is that we now have heteroplasmy. We have at least 2 different groups of cells. Some of them don't have mutation, and some do. So polyplasmy is many, many, many copies of the DNA. Heteroplasmy means some have a mutation, some don't. And this is where some of you already mentioned the number, right? The number is the percentage of red circles versus white circles in the individual. So they take a blood test and they look and they say what percentage of the mitochondrial DNA has the mutation in it. And you get a number like 20%, 60%, 80%. The higher the number, the more red, the more likely is that organ is to be sick, right? And that number of red versus white circles is different in different organs within the same person. Or I should say, it can be different. So this is the reason that you're saying that some of your kids have some problems with organs and not others. It's back to this. So if somebody, let's say, has more problems with seizures or development, that means that they have more of those red circles in their brain compared to their sibling. And if that second person maybe has a sicker heart, it's because they have more red circles in their heart than the other person does.
The diagnosis said it was Murphy-Milas overlap.
Murphy-Milas, okay, so yeah.
So that's what, so it's like.
Lots of different,
Yeah, right,
yeah.
exactly. So, all right, thank you.
So that's that explains the variation, basically. And this is just for mitochondrial DNA. We're not talking about this, that doesn't exist for this DNA over here, all right? So when you get that number, it was probably a blood test.
It was.
Right? So that's telling us what percentage of the DNA in the bone marrow, because that's where our blood comes from, has a mutation in it. But that is not necessarily the same percentage for your heart and liver and intestines and brain and muscle. It can be different. So I'm very careful when I'm talking to families that say, well, we know that it's 20% in the bone marrow because of the blood test, but that's not necessarily the case in other organs. It could be higher or lower. We just don't know. And we don't do that testing. We don't go looking at different organs because it's just a higher risk. We basically just follow to see how the patient is doing. So, yes, sir.
Would that be the average then?
Say again?
Would that be the average that comes out of your bone marrow?
It's the average of the bone marrow in general, but it is not. It doesn't give you any indication of any other organ. It's just the bone marrow. Yeah. And a muscle biopsy. Just talk about the average. If you do it because you mentioned a muscle biopsy, you could do this in a muscle, right? So you take a piece of muscle and you look at it and you say what percentage of the mitochondrial DNA has the mutation, assuming it's a disease due to mitochondrial DNA. That's true for that portion of muscle. But if I took it out of my right thigh, it isn't necessarily saying that my left arm is exactly the same. It's probably pretty close. Yeah.
I just had a question regarding maternal inheritance. So
Yes.
if you have your child, if your child has the mutation, the maternally inherited form of the disease,
Yes.
and you're the mother, how do then you become the carrier? Does that come spontaneously when my mother, I was conceived by my mom?
Not necessarily. That's a really good question. Thanks for asking that, because I should have said that. So when let's say we see a child, we identify a mitochondrial disease due to mitochondrial DNA mutation, right? And we have a number, it's like 80%, right? Now, if the mother has symptoms, it's likely she also has it at some percentage in her, but a lot of times the moms are completely fine. So how does that happen? Well, there's at least two options. One is that mutation is present in her, but at such a low level, it doesn't reach the threshold for causing problems. And we're going to talk about that in a moment, so the threshold. And so it may be that you test the mother and you detect the mutation at like 1% or 2%. And I have patients where we've done this, right? You say, well, you're, at least at this point, don't have symptoms because it was at such a low level. The other possibility is that it's a new mutation in just the eggs of that woman, or one egg. And that's usually what we call de novo. It's a new mutation. So it didn't even have to come, in your example, it didn't even have to come from your mother. It could be just new in a single egg, which means that no other siblings are going to be at risk. But we don't know that. The problem is we don't know that. So once you make a diagnosis, you can test the mother. We say, well, we don't really see it in you. All we can say is that there is a risk for you to have other children with it, but we don't know for certain. Yeah, it's a lot of unknowns with that. So I'll take this gentleman and then you next. Yeah, go ahead.
On the issue of threshold, are there tissue-specific approximate thresholds where you see symptoms?
Yeah, good question. I don't think we know that number specifically. It depends on the tissue. So let me just, because this is another slide, I'll just do it right now. So the threshold is at what point do those mutations have to build up where you start causing symptoms, right? In a tissue that requires a lot of energy, a lot of ATP, that level is going to be much lower. So my heart can't tolerate as many mutated DNA as my skin that doesn't need as much energy. So let's say it may be, and don't hold me to these numbers because I don't think we really know these numbers that well, but it may be that 20% of the mitochondria, when they're mutated in your muscle, that's enough to start causing symptoms. But you would have to get to a higher number in your skin before you started having problems, let's say, or your intestines. So we don't know that specific number. And then the other part of that is, and this is really important to understand, when you or your children get sick, that threshold changes. So it may be that the organ is just fine when there's no problems, but when you're under stress, meaning stress in this case is a fever, or you have an infection, right, or a young woman is having a menstrual cycle, that may be enough stress that at that point the organ is now going to get sick, right? So the threshold can actually change under stress. And that's why when people with mitochondrial disease get sick and they have a fever, we want to take special precaution, because now they're at risk for having a decompensation and getting sicker, because their cells are not able to withstand that extra stress. Does that make sense?
I just have a quick response to you. So my daughter graduated from college last May, and July, 2 months later, we found out that she has a MELAS mutation of 44% on her gene 3243.
Yep. It's the same as this other patient, by the way. The one we started with. We started with the case, it's the same mutation.
Oh, you know something? I walked in late.
That's okay.
I thought you started at 1.
That's okay. I'm just saying this is very similar to the case we started with, but no worries. Go ahead. Yeah.
So Dr. Burano, said she has 44% mutation in the gene. So I went and got tested also. So I have 9%. And I'm extremely, I don't get tired at all. It's like on the opposite end of the spectrum. I have a lot of energy, yet I have the mutation.
Yes.
And so I guess, it might have been from the caveman days that this mutation went down. I don't know.
We don't know. That's right.
So we don't know.
Right.
Where did that start? Did it start back in the hills of Greece? I mean, I don't know. But, so that's the answer. So you and I are the same. We have low, and then our child has a higher level.
what we think is low is better than high, right?
Right.
But this is exactly, so the question is can I say that an individual who has 15% or 20%, right, is never going to have problems? I don't know that. I think it's less likely than if it's 80%, but I don't know that, right? And so it's just a lot that we don't know. But clearly you're not having symptoms, so we know that in your case 8% or 9% is fine, right?
The only thing I have is I've always had a lot of muscle knots all over my back. Not like very, very severe, but you know.
Yeah.
How often does the de novo type of scenario play out? I have VLOS mutation also, 70% in heteroplasmy, but my mom does not. She's free and clear, so I'm obviously patient zero, but
Yes.
that is not a common scenario, right?
It is pretty common, actually. Yeah, I think it is definitely a possibility.
What was the question?
I'm sorry, she said, how common is it where there's a de novo mutation and you don't find that the mother, in the case of mitochondrial disease, has it? And I think it is pretty common, actually. Yeah.
Interesting.
Yeah. Okay, so polyplasmy, lots of copies. Heteroplasmy, there's at least 2 different cell lines, right? I mean, there's 2 different groups of mitochondria, some with mutations, some without. A higher number of mutated DNA, more likely you're going to get sick. That's intuitive. Okay, and then I think the next one is about the threshold effect, which we already talked about, actually. And so we don't need to repeat that. So I just want to now sort of make a little summary here of what we've been talking about. So what determines the clinical variability? This comes back to your question about related to your family. So it's a perfect question, but it took me a while to get to the answer. So now, why is it that each of you that have said MELAS or said MELAS or MERF or conditions related to mitochondrial DNA, there's so much variation? Why is that, right? Why is it so hard to do research in these conditions? Because there's so much heterogeneity even within a given family, and this is why. The first part is the type of mutation. So the mutation you mentioned in the one from the case is a point mutation. It's a little typo where one of the letters in that 16,000 base pair was changed. But you can have a deletion, you can be missing pieces, and in general that's worse than a point mutation. So the kind of mutation is important. But then, what percentage of the mitochondrial DNA are mutated, right? And there can be variation of that percentage or heteroplasmy in different tissues in the same person. And that threshold effect, coming back to your questions are like perfect. It's like outlines mine. So the threshold can move. So let's say my heart, I have, we'll say 20% of the mitochondrial DNA are mutated. So when I'm healthy and I don't have a fever and I'm not, everything's good, that's okay. I may have some dysrhythmia, but okay. But if I get a fever and my heart rate goes up and I'm fighting an infection, now that 20% mutated may make my heart too sick to respond to it. And now I'm going to get difficulty, and that's why we watch patients closely who have mitochondrial disease when they're sick. So that's the threshold changing. And then the last one is, I probably should take that off because it's really not that common. We can actually accumulate mutations over time. This is believed to be part of what contributes to our aging process. And we can lose mutations. And that definitely happens, especially in our bone marrow. You can actually decrease the percentage of mutations there. So, but that's a little more esoteric. These actually play out in families, which is why it's challenging for us when we're meeting with families to give counseling to say, in other individuals in your family, what's the risk for similar medical problems? So basically say you could have children who are more severely affected or less severely affected with different tissues. So, did you have a question? Somebody raise your hand.
I
Yeah.
was saying, once that happens to your heart, right, that the illness triggers the problem, will you permanently now be at a different level of,
No.
will you be sicker?
No, I don't think so. Not necessarily. Yeah, I think you could recover. Yeah. I mean, a good example of that is people who have seizures. I'm a neurologist. I feel I should not even brought up the heart. I don't feel comfortable. No. So with seizures, we know that people who have epilepsy, for any reason, when they get sick, they can have more seizures. It doesn't mean they're always going to have more seizures. Once the illness resolves, they can go back to having the same amount or have seizure control. So you just have this fluctuation. My main point is just when people get sick, if they have mitochondrial disease, you just need to watch them, making sure they're eating, getting carbohydrates, that kind of thing. That's really the main point. Yes. Wait. There, then you, then over there. Okay, go.
Okay, I have an adult daughters with Mito, and they got it from me. One of them has had an infection for 9 months,
Okay.
and it is quite bad, and they cannot get rid of it. I mean, this is at Rush, in Chicago, and now they're not treating it. And I'm really concerned, especially after hearing you, that she's just lying in bed getting sicker with this infection.
Right. So part of the issue is that our ability to fight infections can also be influenced by having a mitochondrial disease, right? So the bone marrow doesn't just make, it makes all of our cells in our blood, and so it makes the cells to fight infection. And it could be that the bone marrow is unhealthy, it's not really making cells to fight infection. And if she has any kind of motor impairment, that increases the risk for infections, those kinds of things. So it's hard. I mean,
She's got a ventilator and train.
Yeah.
She's, you know.
I can't really comment on specific cases because I don't know the whole situation, but I will just say it is hard, and I think it just it's hard for the clinicians to really know what to treat, but it is just like you're saying, it requires special precautions and just be vigilant about trying to treat the infections, because it's going to put her system at a higher risk, and her system is already impacted by having a mitochondrial disease. It's been weakened by that, so, yeah.
What about homeoplasmy when there's like a cheeks? I guess.
Cheek swab.
Cheek swab, thank you, and
Yeah.
homeoplasmic.
Yeah.
mtDNA mutation.
So when there's homoplasmy, so
Yeah.
homoplasmy means all of it was mutated. Yeah, it's 100%.
How do they know from a cheek swab that it'd be all the different?
Well, they don't. I mean, so the thing about a cheek swab is it's basically skin, and so you can do it. It's another way of testing the percentage of mutated mitochondrial DNA, and we think it's really accurate, actually. So what happens in the bone marrow is that the bone marrow is being made over and over and over and over again. So the bone marrow that has the cells that have a high number of mutated mitochondrial DNA in the bone marrow, they frequently die off. And so you can actually get a falsely low number in your bone marrow compared to your skin because the bone marrow. So a lot of people will want to do this because it's a more accurate measurement, right?
So is a homeoplasmic one pretty much dismissed? I mean, that was the sense I got. If it was a VUS that was homeoplasmic, unless I was really, really sick.
Okay, so VUS is back to what someone I think you had mentioned. A VUS is we don't even know if it's pathologic. It's a change, but it may not be. And variants of unknown significance are really common, and they're usually not pathologic.
Okay.
For any genetic condition. Yeah. So a variant of unknown significance is just that. We don't know what it means, but it could be completely harmless. Yeah.
I hope this question isn't too far off on a tangent.
That's okay.
But since you mentioned we need to take precautions with, especially within families with known mitochondrial disorders, where our daughter has not one of the named ones, but clearly some from exome sequencing, mtDNA, and nuclear DNA testing, some severe problems when they have a seizure, we know. Because of that, we took precautions with my son, who was getting his wisdom teeth out. He never had undergone anesthesia, which has been horrible for her. So they took precautions instead of doing, can't have propofol, and she can have compounded blah, blah, blah. And even though we haven't done testing on him, we took precautions. The doctor didn't want to do it in his office. They see what propofol is. They have occasionally lost kids for something as simple as wisdom teeth. So they did it in the hospital, and sure enough, his procedure was in the morning at like 10 a.m., and he still wasn't awake at 6 p.m. at night.
Wow.
And then he ended up waking up at the last second because he finally had to go to the bathroom. But my next son, the youngest, third one, is getting his wisdom. That particular son has had incredibly low heart rate, low blood sugar, low blood pressure. So he's in some low energy. We're not chasing down that rabbit hole yet. But our third son has not shown any signs of disease or disorder right now. But he is scheduled to get his wisdom teeth out, and we're going to go meet with the doctors too. Would you do the same precautions?
Yeah, absolutely.
And do it in a
Yes.
hospital setting?
Yeah, just to make sure. It's just a question about having, for those of you who couldn't hear the question, having problems with anesthesia associated with taking wisdom teeth out. And I would definitely do that.
Is there one anesthesia medication, one thing you recommend?
So, no, but I would say UMDF has published some guidelines on anesthesia, and what I found is just providing that document to the anesthesiologist is really good. It's a really good document, and I just do that too. It's like, and it also lets them know about this organization if they don't know about it. Yep. Yes, ma'am.
Is malignant hyperthermia related to mitochondrial?
Yeah, great question. I think that there's probably some overlap, but it can be all by itself. And so malignant hyperthermia is not necessarily what we consider a primary mitochondrial disease, but you can definitely see things like it in people with mitochondrial disease. But there can be a separate gene associated with that. And that definitely runs in families. And
Right now, we are completely at a loss. I have genetic testing reported from lab, shows complex 1-4 and fatty oxidation, but then I've been told Origin Lab went out, don't go by what they say. I have 4 lesions on the brain, 1 on the spine, osteoarthritis in this side twice. Been told it's MS, then I have some people say no, it's mito, mimicking the MS, but we have no validation to any of it,
Yeah.
and I'm at it for long.
well, so this is the diagnostic odyssey that many people with mitochondrial disease or problems with mitochondrial disease experience, right? And so we are almost out of time. I think we have like, we are out of time. It's actually past 2:30. So let me just real quickly mention, not that it's going to give you an answer, but we haven't mentioned whole exome sequencing because you said exome. There is a test you can do to actually sequence all of the genes in the nucleus, not just those associated with mitochondrial disease. And so that's really where the diagnostic testing is now. So you can sequence all of the mitochondrial DNA, like that circle that we showed, but there's also a way to test all of the nuclear genes, not just those associated with mitochondria. And so that's sort of what we're doing more and more. We're not doing muscle biopsies and all those other tests. We're just getting to the sequencing piece. So, okay, the part we didn't get to, which we didn't yesterday either, was about the clinical manifestations, but I think you all probably have a better sense of that. And so I really am glad we could focus on the genetics. I appreciate your attention, and I hope you enjoy the rest of your stay in Nashville.
Yeah.